Thank you, Dr. Sabri. Our next and last speaker for this session will be Dr. Amin Chouiter from Switzerland. Dr. Amin Chouiter is the head of Interventional Radiology Department in the Neuchâtel Cantonal Hospital, and he is associate physician in 2 hospitals in Biel and Vascular Hospital of Bern, Switzerland. He will talk about the alternative axis. Please, Dr. Amin.
And thanks for the committee for the kind invitations. Is this one? Yes, as mentioned, I will talk about alternate access, pedal and other choices. I have no any disclosure or conflict of interest about this topic. What we learned from the Basel trial is that 20% of attempted angioplasty were failed because of difficulty of re-entry, perforation, also because of difficulty of crossing with the guide wire. So, in fact, 70% of the failed angioplasty was because of crossing re-entry or, in fact, entry also of the lesions. What are the solutions we could have? Re-entry devices like Outback or Pioneer, but limited to the FEMPOP area, or retrograde puncture, assisted artery punction. We nowadays deal with very challenging CTO procedures, and these are some reasons, like heavily calcified lesion, long lesion, and some others. What are the alternate access, in fact? In general, it's retrograde approach. It could be above the knee, or below the ankle puncture site, combined with antegrade approach, and we could puncture a patent or an occluded vessel. Let's talk about the transpopliteal distal SFA approach. We can have the patient in the prone position or supine position, but we prefer to have it in the supine position because the prone position is less comfortable, it's time-consuming with ultrasound puncture, and a higher risk of puncture site complication like hemorrhage or pseudoaneurysm. The supine position allowed us also to have a double approach technique and could help us. I will show you some examples with this total occlusion of the SFA, starting from the upper part here, and heavily calcified lesion through the Hunter channel with very tight stenosis in the popliteal area, P1 segment. The below the knee artery is not so bad, with at least 2 runoff vessels. We start with subintimal recanalization through the Hunter channel, and after crossing this area and making an angio, that we have extravasation with a leakage here in the soft tissue, mean perforation. In this case, we decide to have a closer look, and we see this collateral here, this patent vessel in the distal SFA region, and under this part, down to this collateral, all the lesions are essentially tight stenosis, but not really occluded. So to try with a retrograde approach, to recanalize the SFA, we decide to puncture this area here by this way, and having 60 or 70 degrees help us to have a better push to cross the lesion retrograde. What are the tools you need to make retrograde approach, even SFA or below the knee? Today we have good tools with 21 gauge needle, atraumatic or less traumatic, from Cook. We can have it in 7 or 9 centimeter length, depends of the artery deepness at the area of the puncture site. We combine this with 018 guide wire, for example, the V18, it's what we use in general in our department. It could be a sheetless approach, or with a 4 French until 6 French approach if we plan to use a re-entry device from this puncture site. Here we continue with the case. You can see here the 4 French sheath inside the artery, and the guide wire going up until the antegrade sheath. Some torque, we can go in directly to the sheath, then reverse the situation and work from the tight sheath with still the introducer sheath here in the puncture site. Now we have cross with the 018 wire. Here you can see it down in the P1 segment, all the lesions, and could continue with the procedure after doing the hemostasis with a balloon angioplasty and combine with the external compression like a cuff. Here is the final result with total recanalization of the SFA until FEMPOP area and 2 vessel runoff without any bleeding in the puncture site, even if we use a sheet. In challenging CTO, we have also the difficulty of the entry of the lesion. I will show you just a way to puncture. It's not an alternate access, but it's just how to use the access to start the entry to the lesion. Here we can see the patient with the total occlusion of the SFA, and we tried by oblique view, left anterior, and right anterior view to find the way of the origin of the SFA without any stamp. And we try with angled catheter, even stiff terumo and reverse terumo without any success. Here is the outflow in the level of the P2 segment. So what we decide to do is to puncture antegrade using ultrasound. Here you can see the needle in the common femoral artery puncture site and this fibrotic cuff which we have to cross with the needle. And like this, we can start. You can see here the origin of the SFA occluded, and we can start the recanalization and by the subintimal way with the wire here through the lumen of the vessel. We can after continue with fluoroscopic classical guidance, and finally have this result with the. What about below the knee approach? It's also a double approach, sheetless technique or 4, and now we can have also the 3 French sheet if we puncture at the lower part of the limb. And we prefer to have fluoroscopic guidance more than ultrasound because of easiest way and time consuming to prepare the ultrasound material. We can puncture the 3 arteries, but as it was mentioned earlier, we prefer the posterior or anterior tibial artery and the peroneal artery really in fact in case of no more chains and limb salvage, extreme limb salvage, because of less compression and risk of hemorrhagia. Here you can see this case with the occlusion of above the Hunter channel with no real below the knee vessel, a lot of collateral, but we can see here a phantomatic anterior tibial artery here. We failed from antegrade and we finish always in a lot of collaterals, but no any below the knee real vessel. So we decide to puncture this part of the anterior tibial artery. And here you can see the wire going through the patent vessel until the occlusion. And in this video, you can see we change for 018, then 035 wire, crossing the down popliteal lesion and go subintimal for retrograde recanalization. We snare the wire and continue the procedure with inserting a superior stent in the popliteal area combined with bare metal stent in the upper part, and we can continue with dilatation of the peroneal artery to finish with this result. For below the ankle approach in the down part of the limb, You can also have the plantar, or in the plantar, the pedal approach, you can use the plantar or the dorsal artery. It's a sheetless technique, or also with a low profile 3 French sheet from Cook. Here is the tools we have with this 21 gauge needle to puncture the artery. And here in this case you can see that we are in Rutherford 6 in limb salvage situation with total occlusion of the posterior tibial artery. We try first to recanalize some stenosis or open some stenosis in the proximal part of the peroneal artery, but it doesn't help, so we decide to go to the posterior tibial artery. We try to stay endoluminal, but in fact we couldn't, so we continue subintimal without any chance to re-enter here at this level. We would not to compromise the re-entry of this collateral anyway at this level, so we decide to puncture the common plantar artery at the level just...
Time out, doctor.
Yes, so I'm near to finish. So we puncture and go for a retrograde recanalization, snare the wire, and the final result with this posterior tibial artery patent. Just to finish, I'd like to show you also a case from the literature. Our colleague, Dr. Manzi, showed us a few months ago that we can also puncture the digital from the pedal access, the digital arteries, like here, and he called extreme below the knee intervention. We can see here the wire through this metatarsal artery going through the plantar arch. Here you can see the 3 French introducer sheet with the meeting of the 2 wires from antegrade and retrograde. And in conclusion, I would like to say that it's important to know the material. Nowadays, endovascular therapies are more and more challenging. More than the femoral common artery puncture antegrade or retrograde, we can also use other anatomical access to improve the result of our recanalization. And thank you for your attention.
Thank you, doctor.